Hello and welcome to the UK NEQAS Immunology, Immunochemistry and Allergy webinar series, Mysteries of Myeloma. I'm Dina Patel, Scientific Director of UK NEQAS IIA, and I am proud to introduce the fifth and final webinar in this series in collaboration with Myeloma UK. Alongside myself, we have a panel of speakers. Dr Fenella Willis, consultant haematologist from St George's Hospital in London. Mark Scott, patient diagnosed with multiple myeloma in 2018. Dr Joanna Sheldon, who has worked in the immunology lab at St George's Hospital as consultant and PRU director. And Dr Ross Sadler, who works in the Department of Immunology as a consultant healthcare scientist. So welcome to all. I'm sure you're all very familiar with Zoom by now, but just a few housekeeping rules so we're all aware of how the webinar will be formatted today. So today's webinar will focus on questions from previous weeks that weren't answered, as well as going through cases that have been submitted for discussion by attendees and panelists. So a very big thank you to those attendees that have submitted cases for today. I have collated the cases and we will work through these one by one. Jo Sheldon will present the slides and I will be asking the panel questions on your behalf. So please ensure that you submit your questions via the Q&A section at the bottom of your screen. If we run out of time and we're unable to answer all your questions, either from this week or previous weeks, we will circulate a list of all the questions and answers alongside the recordings shortly. All questions can be viewed by attendees here today. So if you think a question is really important and you definitely want that answering, please feel free to upvote the question by clicking on the thumbs up icon next to the question. The more the question is upvoted, the more likely it will be asked. As we will be working through a number of different cases today, if a question relates to a particular case study, then please can I ask you to state the case number at the beginning of your question to enable me to ensure all the questions are asked in relation to the appropriate case. Otherwise, things may get a little bit confusing. Okay, so we won't be using the chat function to answer any of the questions today, and I would ask that you don't raise virtual hands within this area. We have been recording the whole webinar series, and we will be sending the links to all attendees in the next few weeks. So it isn't possible for us, unfortunately, to provide CPD points as we can't verify attendance. However, we do suggest that people write a brief reflective statement and use that for CPD purposes. So without further ado, I'm delighted to kick off our session by working through some cases that cover various issues, including examples of hidden paraproteins that don't show up on CZE but on immunofixes, differences observed between gels from different manufacturers, and many more other issues. So, Jo, if you could share the slides, please, and we can work through each case that's been received.
Okay. See whether I can.
And if the rest of the panelists also turn their videos on.
Okay, well, good afternoon, everyone, for our fifth and final Mysteries of Myeloma Mysteries of Myeloma webinar session. And really, before we start the cases, huge thank you to Dina and Jen for organising this wonderful session. It's been absolutely fantastic, and the feedback that we've had has been tremendous from all of you delegates, and there have been up to about 1,000 delegates on some of these webinars, which is a phenomenal success. So we hope you've enjoyed them, and this is just sort of rounding it off by going through some case studies that you've all sent in. And we've sort of grouped them together, because there's 8 case studies in total, so it's quite a lot to get through, but we sort of grouped them together to try and give the overall message of them. And this is the first case study from some of our colleagues down in the West Country. We've tried to make them as anonymous as we could to protect the innocence of people. And this is a case of a 76-year-old woman. Her IgG concentration was a little bit low at 5.7 grams per litre. The IgA was 0.7 grams per litre, also a little bit low. And the IgM measured at 7, no, I'm telling you the wrong case. Sorry, my apologies. This is a different case. This is a case with this polyclonal gamma. Can you see on the CZD, so the albumin, alpha-1, alpha-2, beta-1 region, beta-2 region, and this really quite marked polyclonal gamma. Now, if I see what we've got on there, let me see if I can page down it. Okay, so this is the immunotyping of it. And for those of you who aren't familiar with immunotyping, this is the capillary electrophoresis separation just as normal without any addition. This is after the addition of anti-IgG, after anti-IgA, after anti-IgM, after anti-kappa, and after anti-lambda. You can see there's a big drop in the separation. The blue line is after the anti-IgG has been added, and there's a big drop in the IgG. The IgA stays pretty steady, the IgM stays pretty steady, big drop in the kappa, and a not such big drop in the lambda. So this is the case that I would think was very typical of polyclonally raised IgG, where the G goes and the kappa and the lambda goes. But actually, and this is a case that I would say would be very typical of somebody with a polyclonally raised IgG4, because IgG4 runs in this fast gamma region, It's quite broad zone. It's probably a lot of IgG4. Ross, do you see this in your IgG4 cases?
Yes, we do. So we do see IgG4s always presenting, yeah, with that expanded out area on the gamma region. It's always polyclonal. It was a big thing at the early start of discovery of IgG4 cohorts to try and understand that there would be something that would look monoclonal, and we don't find that at all. You find exactly that, just a very large raised amount. And
it's quite interesting because when people think of it being polyclonal, they would think of it being this sort of very even polyclonality. But actually, when it's restricted to one subclass, the polyclonal isn't quite that diffuse. It can be a little bit more restricted. So this is a pattern that would be very typical of IgG4, a massive polyclonal IgG4, but can go up into the 10, 15, even 20 grams per litre in extreme circumstances. So this is typical of IgG, polyclonally raised IgG4. Dina, have we got any questions on this case?
No, not yet. So if there's any questions out there, please submit them.
Okay. Anything else? Any of the other panelists want to comment on? Anything else from you, Ross?
No, I mean, for me, that's the most important part from this, I guess, is showing it as it looks right here, right now, is the immunodisplacement at this point doesn't give you any indication of anything that looks monoclonal.
Yeah.
And I think that going back to the fundamentals, that's where we're seeing in this instance is that there's no evidence that something looks monoclonal.
No.
And that's what we have to kind of just pin down in the first instance.
We have got a couple of questions that have come in now. So the first question is from Mike Wallage, who asks, should we be adding IgG subclasses on if we see a pattern like this?
I think what question would they be asking? We're saying it's polyclonally raised gamma. I think measurement of IgG subclasses is a separate sort of investigation, and there have to be clear indications for it. It isn't just something that you can add on because you're seeing a funny pattern. This is a polyclonal gamma, no monoclonal detected. How about you, Ross? What do you think?
No, I agree. And one of the worst things you can do is start going and testing IgG4, for instance, or doing subclass investigations on something because you're trying to pin down why something looks polyclonal. That's the wrong way round. So if your clinician is saying, I think I've got a patient who clinically looks like they've got IgG4 disease, for instance, then do an IgG4 level to help them out. But I'm not a fan of us reflexing on something as vague as something that looks polyclonal in the gamma. That would be, you're going to create an awful lot of effectively false positives if you're looking at it from an IgG4 perspective. So I wouldn't recommend that.
Lovely. Okay, next question is from Francis Smith, who asks, would this be similar in IgM?
In a polyclonally raised IgM, is that what he's meaning?
I think so.
It can be. You can get massive polyclonally raised IgMs as well, and it could look very similar to this.
Okay.
Immunofixation and immunotyping are very useful tools when you have that polyclonal gamma, and you can't quite explain why. So, so I think, yes, with a poly-raised IgM, it could look very similar to this. And IgM usually runs up in the bath gamma as well.
Okay, lovely, thank you. Next question's from Irina Badrov, who asks, can you please clarify what is immunodisplacement? We don't use this terminology at their place.
Oh, that's your term, Ross.
Sorry. Yeah, so there are two ways to further investigate your initial electrophoresis in order to try and determine what you're seeing in there in the gamma or beta or anywhere region, really, to try and understand if it has an isotype, a specific isotype, whether it's G, A, M, E, D, kappa, lambda. And so our traditional method is to do a gel-based immunofixation, which is what we have done for a large number of decades. Then the second option, which is newer, is to continue using the same technology of the CZE platform, but instead effectively add anti-sera in and see it quenched and it's subtracted. So it could be called immunosubtraction instead of immunodisplacement. It depends which way you round. I mean, immunodisplacement is the word I would use, but it can be multiple words. But what you're seeing here on the screen is that representation of that methodology. So it might be that in your lab, you don't have this technology. If you're using a gel-based electrophoresis method, you can't really do immunodisplacement. You'd have to rely on immunofixation to do it.
Okay, thank you. Next question. Irina's just said they call it immunotyping.
Yeah, I mean, immunotyping for me is a more generic word that is used. You could define immunofixation and immunosubtraction / displacement as immunotyping, because you're trying to type it, you're trying to come out with an answer at the end. It's just there are multiple ways of achieving it.
Okay, lovely, thank you.
If you think about what happened is when in this track, for example, you've added anti-IgG. The IgG in the patient's serum has bound on to the anti-IgG in the little cup, and it's actually moved it away from where it runs here. The antigen-antibody complex is no longer running here, it's moved elsewhere, which is why it sort of disappears, which is hence the term we used to use was immunosubtraction. You're taking out the IgG from this track by adding anti-serum to it and moving it somewhere else. Here you've added anti-IgA, not much has happened because you haven't got enough IgA to remove or move away. The kappa, when you've added anti-kappa, the antigen antibody complexes, the anti-kappa kappa complexes have moved and has had to land. So that's why it used to be called immunosubtraction. But immunotyping is a better term, I think.
Thank you, Jo. Okay, next question from Artan Seeker. I hope I've pronounced that correctly. The peak in the kappa fraction has disappeared too in the I-type.
Dina, just to check the questions just moved at the second you were reading it. So Artan's question is now the second one.
Oh, yeah, right. Okay, I'll go to Artan's. Right. The IgG4 seems to be restricted to kappa. Isn't it something not normal? Should we consider this as gammopathy?
No, IgG4 is predominantly, is much more kappa. If you think the kappa lambda ratio of IgG4 is heavily weighted towards kappa. So that's exactly what you'd see. You'd expect to see much more G and kappa disappearing rather than G and lambda, because the kappa lambda ratio of G4 is about 8:1.
Okay, thank you. The next question is from an anonymous attendee. For the biochemists in the audience, can you clarify how IgG4 disease would present clinically?
You happy for me to this, Jo?
No, it's for you, definitely.
So, okay, so IgG4 historically used to present, we originally characterized it as a disease that represented from a pancreatitis. And so actually these patients were presenting originally looking at suspected pancreatic cancer. And in the original early years, say the mid 90s to late 90s, a lot of people were having their whole pancreas removed in a Whipple's procedure, and then finding out that if you gave them some steroids, it would rectify the problem because it was an autoimmune disease. That led to further investigations, and really what we've now learned is that this is a disease that can present all over the body. It's usually glandular, but it can present in other pieces of tissue as well, multiple organs, and it's characterized by this mass infiltration of lymphocytes, which also shows a high percentage of IgG4 positive plasmablast B cells in it. And it can cause different levels of pathology in each of those, but normally you're seeing an enlargement and swelling due to the infiltration and the development of almost kind of pop-up shop equivalent of germinal centers being made in the organ or in situ in the tissue where they shouldn't be. So that's normally the presentation, is the organ is going awry, and it's usually a glandular tissue is normally what we tend to see.
Lovely, thank you, Ross. Final question, and then we'll move on to the next case. The peak in the kappa fraction has disappeared too in the I type. How is this not considered an MB?
Because it's not just the disappearance of the band, it's also the pattern of it. And it's actually, you're losing both kappa and lambda. So this is, and it's a very typical picture of a polyclonal gamma. And do you remember maybe in week 2, we were talking about some of the difficulties of interpreting immunotyping. And this is very much one of them. It's a lot of experience that would say people like Ross and myself say, oh, it's polyclonal. This is a very typical picture of polyclonality. Although a lot more kappa has gone than lambda, it's the pattern of it and the distribution of it that would say it's polyclonal. And if you think, I don't think I've ever seen a monoclonal that would span the entire gamma region. So that's really another hint that this is a polyclonal picture.
I would say that one of the things and was mentioned in the week 4 presentation was the idea that says using this methodology is something that can be much more efficient than having to do immunofixation gel-based methods. It is a much easier way of doing it. However, there is a level of interpretation experience that needs to be done with it. And there is no magic number for when you should use it, when you shouldn't use it. And that is very much about the experience of the team using it. So if you're in a team where you look at something like this and you are not confident, you really need to consider using going back to immunofixation as a method that will, my personally reading, even though it's still subjective interpretation, it is something that gives you a much clearer answer in the way that you're determining it than doing something along this method. So this method's brilliant if you have a peak that looks akin to the albumin in here. It works phenomenally, and it's great. But when you start getting things that look a little bit less distinct, if you don't have the experience, you can build that experience up by doing some parallel testing and going back to it and auditing it and learning from that, and then gaining some confidence.
But one of the other disadvantages is if you've got, as you said, a big peak like the albumin, there's no problem in detecting that pretty much by any method. Yeah. But what you may also find is if there's a little bit of retained light chain, retained monoclonal light chain, you're kind of consuming all the antiserum, typing the big paraprotein, and you miss the little paraproteins because there isn't enough excess antiserum to find it. And that's one of the things that we find when we get samples referred to us, is that they type the big paraprotein, but they've completely missed the retained Bence-Jones protein because there just isn't enough sort of antiserum in the mix with enough affinity and avidity to grab the antibody from the immunotyping technique. So I think it has limitations, and I would always personally always favour immunofixation. So if you're just wanting to drive a load of samples through, then this would be the way to do it.
Okay, thank you. If we can now move on to case 2.
Case 2. Now, actually, this is going to be kind of case 2, 3, 4, and 5. because we've had a really interesting selection of samples of cases which show a very similar thing, and we call these disappearing paraproteins. And these are all situations where no paraprotein band is seen on capillary electrophoresis. All of them have a raised IgM concentration measured immunochemically. All of them have a paraprotein, an IgM paraprotein, that's completely obvious on the immunofixation. And across these 4 cases, we've got 3 IgM kappas, 1 IgM lambda, not unexpected. And we've also got an IgG case in case 6. So I'm going to whiz through them reasonably quickly, if I can get my thing. Yeah. So this is the first, this is case 2. This is the one I started telling you about at the beginning. This is a case from our colleagues down in Dorset. This was a 76-year-old lady who had a raised IgM concentration at 7.9 grams per litre. And those of you who are familiar with electrophoresis say that looks an absolutely bog standard, completely normal electrophoretic separation. I wish I could ask how many people would immunofix it, but based on that, I think most people would say, no, it doesn't. Maybe the gamma looks a little bit lowish, but based on that, I don't think people would immunofix. And then if we look at the immunofixation, we see an absolutely crystal clear IgM kappa, lovely IgM kappa, smack dab in the mid gamma. So if we go back, yeah.
Joe, we've had somebody ask then, an anonymous attendee asks, why was a fixed on if no monoclonal band was seen on the electrophoresis?
Because of the IgM concentration of 7.9 grams per litre. Do you remember in one of the previous weeks, we said one of the reasons to immunofix is if you find an unexpected raised, particularly IgA or IgM. And so this would have been immunofixed, I would imagine, because of the raised IgM. Certainly in our hands, and I'm sure it will be the same in Ross's hands, if you find that pattern with an IgM of nearly 8 grams per litre, it would warrant an immunofixation. Now, one of the other things that it would cross our minds would be, could it be a cryoprotein that's completely disappeared? But we wouldn't, but we would expect to see some precipitated maturity if that were the case. So that's the first case of these raised IgM. And this is a case from our colleagues in Dublin, where we have a raised IgM again at 5.1 grams per litre. And I think next, this is the immunotyping. So this is the normal electrophoretic separation, no obvious paraprotein. A little bit of poly G is gone, not much has gone from the A. The little bit's gone from the IgM, so it looks like the paraprotein is in here, little IgM kappa running up here in the beta region of the electrophoresis. A little bit of lambda's gone. But if we go back, I'm struggling with my computer, I'm afraid. Okay, so there's quite a distinct difference between the capillary electrophoresis pattern and the immunofixation. And actually on the capillary electrophoresis, the band is running more up here, and on the gel, it's running in the mid gamma. This is something again that we definitely see. There's an element of molecular sieving in the gel of the immunofixation, and that undoubtedly can alter the electrophoretic mobility of proteins, especially IgMs, sometimes IgG3s, but actually it can affect any of any monoclonal protein. So a little bit more molecular sieving in the gel makes some paraproteins run in a different place. The other thing about IgMs, and I mean, it's old-fashioned knowledge, but if you remember, IgM is actually a pentamer, and we call that 19S, S for Sedberg, so that's the sedimentation coefficient of IgM. And occasionally, paraproteins don't get, IgM paraproteins don't get linked together with the J chain, and so you end up with monomeric IgM, so 7S IgM. And that's something that you can occasionally see as a reason for these differential mobility in IgM paraproteins. So that's the first one of these. Let me go through a couple more and then we'll see what other comments people have to make on
We've
them.
just got one question so far, Joe, from an anonymous attendee. How does this relate to a sticky M?
The sticky M. Sticky M's are usually big IgMs that stick on the origin, so they don't actually move on the immunofixation. And interestingly, sticky M's aren't usually so sticky in the CZE. They're more sticky on the gel. So neither one system is perfect, and we have some paraproteins, and it's a feature of the paraprotein. It's not so much a feature of the various systems. Some paraproteins actually work better on the CZE, and some paraproteins you actually see clearer on the gel electrophoresis. But a sticky M is much more related to the gel, and it usually sticks on the origin. It doesn't. It's so big. The molecular weight, or it's usually immune complexes or aggregated immunoglobulin, and it's so big. However much charge you put on it, it doesn't move on the electrophoresis. It just stays there. And then on the immunofixation, it doesn't wash out very well. Don't forget, a sequence of the immunofixation is washing out all the unprecipitated protein and unbound antiserum. So because the protein is so big, it kind of sticks on the origin and it doesn't wash out. So you often get an immunofixation with a tract that goes right across all five DAM, kappa and lambda. So a lot of non-specific staining because it hasn't washed out. So if I go on to case 4, this is a case from more colleagues down in the west of the country. So this is a 53-year-old man, a 7-gram per litre IgM, and this is a separation where they think the paraprotein might be in here in the gamma, and yet on the immunofixation it's an absolutely obvious IgM lambda paraprotein. And then another case 5, another case from the West Country, nothing remarkable on the electrophoresis, and an absolutely obvious IgM kappa running in the mid to slow gamma. So these cases all are showing this differential mobility. So in the electrophoresis, you're not seeing the paraprotein, and on the immunofixation, it's coming up very clearly, and either coming up from nowhere or coming into a different position, with a different electrophoretic mobility to the original electrophoresis. So what about you, Ross? Any other comments on this?
I think the moral of the story more than anything about this is enhancing the reasons that we've said you need to run immunoglobulins alongside your electrophoresis, because in all of these cases, what we're seeing is a thing that says, you know, if you just had your CZE trace and that was your methodology and your workflow, you would have put this out as normal. You then might have done some immunoglobulins at a later stage, or you might have tracked it back. But by running them at the same time and making that assessment at the same time has enabled questions to be asked at the right time point. So I do know that there are some settings where workflows in people's LIMS systems will run that the immunoglobulins get done first, they're then immediately authorized out straight away, and then the electrophoresis is done at a later time point, and that might be authorized out. I thoroughly encourage people to try a process where they actually hold and only let the results out in one go, because you're making an assessment based on all those values at the same time. And it helps your users have visibility of what the results are when you're happy to release it because you've finished what you're doing. You can put an interim comment out that says something wacky's going on, we're just working on it. But this is all of these cases show exactly that same concept that says you need to have that other piece of data available so that you can make your full evaluation at the right time point.
Okay, we've got some questions coming in. First one's from Marlene Courier. We have a known sticky M patient whose IgM band is not visible in CZE, but is in gel. Oh, I've lost that question. Sorry, give me a minute, I'll just find it again. Yep, so we have a known sticky M patient whose IgM band is not visible in CZE, but is in gel at concentrations of about 6 to 7 grams per deciliter. We're not sure why this is. Any ideas?
6 to 7 grams per deciliter or grams per litre?
It says per deciliter.
So 60 to 70 grams per litre. Oh, that's quite a big band. I think it comes down to that molecular structure again. You can try diluting the band. If it's that big, if it's really grams per deciliter, you can try diluting it, maybe 1 in 5, and see whether it'll run better on the CZE when the concentration has come down. Otherwise, then run it on the gel and quantify it through the gel electrophoresis and scanning of gel separation.
Okay, thank you.
Next, we excluded a cryo.
Yeah, that's the other thing to consider, isn't it? Yeah. Okay, the next question is from Mike Wallage, who asks, at what IgM level should we consider immunofix given a normal looking CZE trace?
I don't think there's a specific number. Maybe, you know, above 3 grams per litre, above 4 grams per litre, but if there's nothing else, yeah, we would probably fix an IgM above 3 grams per litre. How about you, Ross?
Yeah, I was thinking there isn't a hard and fast rule here. It does relate to what the trace looks like. So if you look at, I think it was case 2, that one was about as flat as you could possibly ask for. I mean, there really was nothing there, and you had one that was 8. And there is a correlation between the two things that you can see. And so I think that I agree. We sit around the idea that we'd say probably 4 to 5 or something like that, approximately. But you're sitting again at an idea that if you can see something on the trace, then it can potentially lend confidence that you're capturing things suitably or not, etc. You also want to be thinking about what other immunoglobulins are looking like. The person could be someone who comes in and you've got Barnd, or they've got liver disease on the clinical details. They've got a raised IgM and a raised IgG. Might have a raised IgA as well. At least you've got something to play with.
Mitochondrial antibodies and PBC, and there are. Yeah.
So you've got something to play with there. That means that you can make a decision that's a bit more sensible. So it's dangerous to have absolute hard and fast. I do think you probably have an essential cutoff that says if you've got something over 5 and your electrophoresis is saying normal, then that's your kind of hard and fast. Maybe you can go lower, down to 3. You probably need to look at your workflow and try and understand what implications that has on how many you're going to change and how many you're going to do. But
see, something we do is we fix M-kappa lambda. We don't necessarily do a full fix. If it's just an isolated M of 7 grams per litre, we wouldn't do because immunofixation is much more flexible, we would just fix for M-kappa and lambda. But it's important that you do immunofix, because if you can't see the band on immunotyping, on CZE, it's going to be more difficult to find that band.
Okay, I'm going to combine 2 questions together from Orla Maguire and Eleanor Wallace. How do you quantify paraproteins in cases 2 to 5, and which method is used for quantification of paraproteins in these cases?
If you genuinely can't see the band, then you can run a gel and do scanning densitometry of the gel and quantify the percentage of the paraprotein band as percentage of the globulin, because don't forget you've got the differential dye binding between albumin and globulins. And we would always make a note of the measured IgM concentration, and you can use that, although report it with a comment saying this may not be an accurate reflection of the quantity of the paraprotein concentration because it's immunochemically measured. But scanning densitometry of the separated gel would be the preferable way of doing it.
Okay, so we have got quite a few questions that have come in. So the next one is from an anonymous attendee. Disappearing IgM. Do you give users any ideas of the PP size for bands that aren't visible on CZE? If so, again, how do you quantify, which you've just answered?
Yeah. Yeah, so we would report it with a comment saying this is it's a good way of starting. This is an interesting sample. The paraprotein band is not visible on our capillary electrophoresis method, but it is clearly seen on immunofixation and on gel-based techniques, and this is how we're going to quantify it in the future.
Okay. And then another anonymous question, case 2 to 5, would you report the quantitative measured IgM from your nephelometry in these cases? We would usually not report the affected immunoglobulin in a paraprotein patient.
Yeah, absolutely. If we genuinely couldn't quantify it, then the only thing we could do would report the immunochemical. But if we can quantify it, for example, by densitometry of the gel, then that would be what we should, that would be the preferable way of reporting it.
Yeah, I would say, I can see a lot of questions circling around this concept. Again, the most important thing you do is that you keep a consistent method of what you're going to do and when you're going to use the total immunoglobulin amount and when you're going to try and attempt to give a concentration. And you know what Joe has described about taking the gel and doing it is absolutely the gold standard method of doing it. If you don't think that's pragmatic in your workflow, again, then you need to find the solution of what you can do and make it consistent. And most importantly, you need to make sure that particularly your hematology team understand whatever it is that you're going to put out and what that scenario represents. So a common thing I see users will sometimes come back and say is they go, hey, I've been really interested because you keep writing the word beta in my comments and I've got no idea what beta means. So make sure that your user understands the comment you're putting out. We are all, and myself especially, are guilty of putting comments out that make perfect sense to us because we're looking at this gel or something else. The user sometimes, you know, has got no visualization of what you're doing when you write that comment. So make it clear and almost agree it with your users. When this happens, we're going to do this and we're going to give you this answer. And that's what that represents.
Okay, one final question before we move on. Why do you not see the IgM on the CZE? Is it hiding under another band?
I think there's a number of possibilities. One, it could be hiding under another band, although I don't think that's the case in all of these situations. The band's just a little bit too big. When we first looked at CZE, one of the issues was the temperature that the CZE was working at, and these funny IgMs kind of got left behind. So they didn't come out, CZE, it comes out in backwards. If you look at capillary electrophoresis, the thing that is read off the in the optical window first is the gamma, and followed by, it goes back, the last thing that comes out is the albumin because of the charge on the capillaries. And so these big IgMs, both the temperature but possibly also the pH of them they get left behind, and they don't come out within the capillary separation. Now, back in the day, they altered the temperature and the buffer that the CZE was working at, and that pretty much resolved most of these issues. Clearly, not all of them, and some funny IgMs still behave in this strange way. And this is really much more a feature of the paraproteins than it is of the electrophoresis. And don't forget, every one of these paraproteins is individual. We talk about it as IgM, but it isn't like IgM like we would normally think of it. The molecules can be fractionated, they can be monomeric, not pentameric. The IgM individual molecules can be truncated, they can be they're not normal, they're not produced by normal B cells, they're produced by malignant B cell clones. And those B cells have lost the instructions, they've lost the rules. So these aren't normal IgM molecules. They're very often aberrant IgM molecules, but we can still identify them as IgM because they still have some of those characteristics, but they're not normal IgM that we would expect, you know, in a normal IgM in a normal person.
Okay, lovely. If we can move on to the next case now, please.
Okay. Okay, case 6. This is a case from our colleagues in Manchester. Now they obviously have a selection of different equipment, and I don't know whether the equipment has been in the lab all at the same time or whether they've moved from one system to another. But they have a Helena system, but they've also had access to a Thebia system. And they have a paraprotein where they have a difference in mobility between the two systems. They were also advised to use a different buffer for such proteins. So, for example, here's the Thebia separation, And this is where the paraprotein is running in the Sebia separation, in the Helena separation, I'm sorry. And then on the immunofixation, it's gone from really albumin alpha, sort of alpha 2 region to slow gamma. We've had 4 cases that are IgMs, but this is an IgG kappa paraprotein with a nice a high IgG concentration. And this is really quite a marked difference in mobility from that sort of alpha 2 beta region right down to the very slow gamma. And then the next, and then this is to say a similar sample from the same patient run on the Sebia capillary system, and here you can see that the paraprotein is migrating in the slow gamma, like the immunofixation does. Let's see whether we've got one more slide on this one. And this is the Sebia hydrosis immunofixation, again showing the paraprotein in the slow gamma with the slow gamma mobility. You can also see, can you see here this staining that we can see in the A, M and lambda track? This is probably, I would say that this might be a high molecular weight aggregate, and this is where we haven't successfully washed out all the unfixed protein in the unbound protein. So it's caught up in the matrix of the gel, and I don't know, but this could be an IgG3. It could be a cryoprotein, and this is really this is what we call as a sort of a sticky sample, where it's sticking in the matrix of the gel. Is that the last one on this one? Yeah, so Manchester very kindly offered us some discussion points. So they said this isn't standard practice, and they were wondering whether any other users of the Helena systems have encountered this issue when they migrate differently in the different media. And the use of this Zoom buffer, it's not a buffer I'm familiar with, but have other users used the Zoom buffer and found it useful? And how have other users dealt with these discrepancies? So over to you, Dina. Any questions coming through?
No.
Are there any other Helena users out there who might have had this issue?
I can say that we're a Helena user, and I'm not aware of us having that issue. I'm happy if anyone in my lab is on the call for them to tell me I'm wrong, but I don't think we've seen that issue in our system.
Yeah. So Ross, is this a very typical Helena separation?
Do you mean for that initial one? Yeah, I would say that looks pretty typical. Yeah.
And are they usually this sort of compressed, or are they a little bit? Can you make them a bit bigger?
You can make them a little bit bigger. Yeah.
We have a question.
It makes your eye. Yeah, the albumin and the albumin in this band look, not that dramatically different. If the albumin was a bit higher, it might. Yeah,
no, you can. Yeah, you can get that expanded out. So yeah, you can definitely fix it to change the scale out for it.
Okay, we've got a couple of questions. The first one's from Irina Nagy. Would Fluidil from Sebia or BME help in this case?
Okay. I will not use mercaptoethanol. I think it smells disgusting and it's much too aggressive for proteins. We use dithiothiazole, DTT, and we use it. We dilute the sample and we add 1 milligram per mil DTT, mix it up, and then pop it onto the immunofixation. We don't usually run DTT through our capillary electrophoresis, Sebia likes Fluidil, but I think DTT is such an easy. It breaks up the aggregates. It breaks the bonding within the quaternary structure of the molecule, so it opens it up a little bit. And I think a little bit of DTT works a treat on these. I don't know whether it would have helped in this situation. What do you think, Ross? Would you have?
We wouldn't. I don't think we would have gone down the road of treating it. I mean, we do use beta mercapto, but very sparse. The smell.
Yeah.
But yeah, we don't get it out often for things, certainly things like this. We wouldn't put it out.
Okay.
Yeah.
Another question that's come through from Lynn Fallows. We have seen it. Sometimes the Zoom buffer helps, but some patients we still had to do by gel. So nowadays we just do them all by gel.
Yeah. What's in Zoom buffer? Is anybody there that can tell Dina what's in Zoom buffer?
I will wait for them to come through, but the other question we've had from Aluna Roberts is, with the Zoom buffer, did the paraprotein migrate in the gamma region?
Oh. Can I see that from the slides that they've sent? They sent us, Manchester were incredibly helpful, sending us a whole load of slides. I think the Zoom, I don't think the Zoom buffer helped. Oh, yes. Yeah, the Zoom buffer did move it. The Zoom buffer analysis shows the altered mobility of the paraproteins, so it now runs in the gamma. So yes, the Zoom buffer did help on the Helena system.
Lovely. And Siobhan Easter's kindly sent in some information. It's a different pH to the CZE buffer.
Right. Okay. Right. Well, it's something that Helena users may want to get a little bit of Zoom buffer in. It sounds like something that we should be doing on our telephone call, shouldn't it?
Siobhan also says that the Zoom buffer helped, but they were concerned they would be missing other paraproteins because of it.
Yeah. And this keeps coming back to, if you're looking at electrophoresis, you need those immunoglobulins to put the two things together to interpret the whole pattern. And these situations, they're not incredibly common, but they're certainly not rare. And so regularly we will see samples that don't work on one system or the other, and having the immunoglobulins and the electrophoresis there to make a full interpretation, I think is absolutely fundamental.
Thank you, Jo. Can we move on to the next case, please?
Okay. Oh. So let me just. So this is the case from our colleagues in Shrewsbury, a 61-year-old man with a GP request with, I won't go through all the results, you can read them as easily as I can, but the important thing is he has a raised IgG, a raised IgA and a slightly raised IgM. And I think I would be expecting to see a polyclonal pattern in this patient. And sure enough, there's a polyclonally raised gamma with a little bit of beta gamma fusion. We did the kappa and the lambda, and the kappa is a little bit raised. What's the top of the reference range for lambda? Ross, is that a little bit high as well? 31?
Yeah, only marginally. But only marginally.
And then a ratio of 2.18 is fine, isn't it? That's within the normal range, isn't it?
It's slightly out. It is slight. It depends at well. So at the age of the patient, yeah, it is slightly out. But even in our hands, we would say the ratio goes up to about 1.8 probably. So it's slightly out, but it really is marginal.
Right, but definitely tending towards the kappa than the lambda.
Yeah.
Yeah. Okay. So then their capillary electrophoresis, so polyclonal gamma, beta gamma fusion, and they've highlighted this tiny little zone at the sort of the top of the gamma region. And because they saw this zone, they did an immunofixation, and they're a bit grainy, and that's probably because of the way that we've had to pick the images up. But you can see a little tiny zone in the lambda, and as would normally be expected, if you find anything in the light chain, a light chain only, also check D&E. Little lambda zone remains, no D&E. And then they've also checked it for free kappa and free lambda, but there's no free kappa and free lambda in there. So I would think that in our hands, what I would do is I would rerun this immunofix, and I would increase the dilution of that IgG track, because I'd put money on this being a little tiny IgG lambda zone in the middle of the gamma. The thing about the lambda is you see it much more clearly because you've got a lot less background. You don't see the kappa zoning because you've got all of that polyclonal kappa. You've got about twice as much kappa than you've got lambda. But you see a little zone in the lambda because you've got much less background. And it's a very common thing that we get in the PRU is query retained lambda BJP in a polyclonally raised gamma. And actually, if we take the dilution down, what we'll find is a corresponding little IgG to go along with that lambda. How about you, Ross? What would your view on it be?
Yeah, so we see ones like this every so often, exactly the same, where you feel like the results don't all correlate up, because you're seeing something that looks monoclonal IgG lambda, yet your serum free light chain profile is showing that there's a kappa bias, and that can make things look all discombobulated. I agree. We would most likely say this is an IgG lambda, and it comes back down to the idea that says here you've got someone who's potentially got a very small clone, that a monoclonal that's standing out amongst the background on the lambda, like you said, but there is a kappa, there's a predominant kappa background here of polyclonality, and we can see that because I think the IgG, total IgG was something like 22 grams or something, yeah, wasn't it? So and the A is raised as well. So there's definitely no question that you've got a large amount of polyclonality going on in here, and that's really affecting your serum free light chain correlation here with what you're seeing on fix, and that again comes back down to what I've said before, is a serum free light chain result is an indicator. It's not a confirmer, and fix really is your confirmation of saying, is there monoclonality or not, and that's what you would go on. That's what we would go on in Oxford here, is we would say we can see it in the fix as a monoclonal. That's where we would run it.
Okay.
Our we said we suspect that this is an IgG lambda paraprotein, but the antiserum for the heavy chain didn't pick it up, probably masked by the polyclonal background. Absolutely, you just need to get rid of some of that poly background, dilute the G track more, and I bet you that a little IgG zone will appear.
Couple of questions. First one from Suzanne Fugel, who asks, would you ever use the CRP result to help interpretation?
You can do, but I don't think it'd help in this situation. It may or may not be raised. The alpha-1 and alpha-2 don't look particularly raised, so the CRP probably isn't going to help very much.
Okay, next question from Artan Seeker. Free light chain assay would help in this case. Did they do that? Yeah,
free kappa lambda, 68.5 for the kappa, 31.4 for the lambda. So it actually confounded rather than helped.
Yeah, okay, thank you. Okay, if we can move on to the final case then, and hopefully we'll have a couple of questions.
Right, so this is the case from our lovely colleagues in Malta. This is a 48-year-old man who presented with vasculitis and then a cryoglobulin investigation. If I come on to the pictures, here is the tube of the sample at 4 degrees C with what we can see is a large precipitate, a large cryoprecipitate that I think appeared quite quickly, and they're worried about whether this is really a type 1 cryoprotein or or overlapped with a type 2. If I take you down to the immunofixation, this is an immunofixation. It's not a very beautiful immunofixation, and I think that's most likely a feature of the sample. The sample is very thick and gloopy with that big cryoprotein in it. And although you can see the IgM kappa, there's an awful lot of kind of streaking and really not a very nice immunofixation. And actually the capillary electrophoresis doesn't really show the band at all. That's because the band's actually precipitated. One of the things that we would do in this is make sure that we had our warm sample loaded onto the CZE immediately before it was going to be sampled. So it comes straight out of the 37 incubator, straight onto a CZE rack and goes through. And if that doesn't work, then we dilute it in a little bit of warm saline, maybe 1 or 2 or 1 in 3, and then pop it onto the CZE, and you'll see that the band miraculously appears. The cryos often dissolve better when they're more dilute. So diluting the sample will be quite a successful thing to do. And the same with the immunofixation. Same with the immunofixation. Diluting the sample a little bit more, maybe adding a little bit of dithiazolidine will help resolve this even better. But this is the feature of the sample. Now, I think the reason they were concerned about it being the potential of being a type 2 is because of the presence of a strong positive, of a positive rheumatoid factor at 136 international units per mil and a low complement C3. About, I don't know, 10, 15%, 10 to 12% of all IgM paraproteins have rheumatoid factor activity. So just because it's an IgM with rheumatoid factor activity doesn't really make it into a type 2 cryo. Similarly, just because the complement is a little bit low, if you've got a lot of immune complexes, you're going to activate complement. And that's why the C4 is low. So I think this is, as they say here, generally it's a characteristic for type 1 cryoglobulin. And I don't think I would say a type 2 cryo was present. This is very much a type 1 cryo. How about you, Ross? What do you think?
No, I think you present a very fair case in what you're saying. I think probably I would just be, I think the most important thing is that, like, there's got a lot of information on this report, which is great. And it's very clear to the user. The ultimate request is the patient's got vasculitis. So I think in some regards, they're hedging their bets that it's a type 2. They're trying to rule out, aren't they, potentially a type 2 cryo here to lead to that vasculitis in the first place. So that would be the only thing that I would be making sure on the report, that the user is aware of it. I think realistically, the result is showing evidence that says the clinical user is going to have to they can't just rule out now that this isn't a cause of that vasculitis. So they're going to have to investigate that part of it. But other than that, everything you've said, I agree with.
The other thing I think is absolutely crucial in this case is an urgent phone call to the clinical group and haematology, because this patient really needs immediate treatment with for example, plasmapheresis. So this patient needs to go down to clinical haematology and be plasmapheresed. And once that paraprotein, once the cryoglobulin has been by, they can have another look whether there's any evidence of a type 2. But I think generally it's the predominant pattern is of a type 1 cryo. And that's really, that looks nothing like a type 2. So I think it's a type 1 cryo needing urgent action. Call to the haematologists.
Okay, and I think that'd be quite a good point, actually, just to raise that if anybody out there has any plasmapheresis material or urine material that's got BJP, we would be extremely happy to send over a courier to pick up the sample, because we would appreciate any material available to circulate within the EQA scheme. So if anybody has anything special out there, please get in touch with us, and you'll make our year probably. So thank you.
You're easily pleased, Dina.
I am. It doesn't take much. A bit of urine
makes Dina happy.
Joanna, I was going to say, just one of the things that's quite important is often we have discussions between both renal and haematology, because these cases are often not necessarily straightforward, and particularly patients presenting via a renal route where it's not completely clear whether it's a vasculitis or not, and we often have to do joint sort of investigations along both the renal and haematology route before we get to a definitive diagnosis. So you're right, both the clinical pathways need to be alerted.
Thank you. Okay, so we are running out of time quickly, but I think we may be able to fit in a few questions. So if we could go down to the questions, please.
Oh, sorry.
Okay, so this is a question for Mark from week 1 from Cade Flowers. Apologies for the potentially personal question, but was your pain limited to your back and hips at its worst, or was the bone pain more spread out?
At the start, it was quite localized and was mostly in my lower back and hip. That would be around kind of mid-February, March. By July, it was extensive across my entire upper body to the point where I was completely bedbound and couldn't get out of bed. Yes, so on diagnosis, I was literally completely limited in my movement. I couldn't sit up or move effectively, to be honest.
Okay, thank you, Mark. I think the next question's for you as well. With the benefit of hindsight, were there any signs and symptoms, Mark, that you recognise having early on that you think might have been linked to myeloma, or was it mainly back pain?
To be honest, I hadn't heard of myeloma until the consultant at Wigan was explaining what it was to me. So all through I just accepted the diagnosis of the my GP, physiotherapist, A&E doctors that had just said it was a back pain issue, a slip disc or a trapped nerve perhaps. And I think really I could have pushed a little bit harder to maybe encourage further investigation on that. But like I say, I'd never heard of it until I was told I had it. Yeah.
Okay, thank you. Okay, next question. This one's for Fenella. Considering how long it takes to diagnose a case of multiple myeloma in the UK, I'm wondering if there are surrogate markers that should give a clue to multiple myeloma, especially in the LMICs.
Okay, let's get it straight. It's not all patients that take as long as Mark to be diagnosed. So it's about 40% of cases that are have some form of delay in diagnosis. But actually, if we look back, and obviously it's very important for GPs to be aware of early signs that might pick up a case that should be investigated. And from a laboratory point of view, the early markers are anemia, and a raised ESR. I think those are probably your two earliest biomarkers. And then at a later point, usually when there's significant tumour burden, things like renal impairment and hypercalcemia might occur. The other thing that's quite useful and is routinely done through GP surgeries, particularly for patients with diabetes and hypertension, is urinary dipsticks for protein. And obviously, you know, if there are routine dipsticks being done for protein and unexplained heavy proteinuria, that's the other time that a myeloma screen should be considered.
Okay.
And I check that because the dipstick will only detect the albumin; it won't detect Bence-Jones, so it will have to be the albumin because of the renal impairment due to the damage from the light chains or the amyloid, for example.
Yeah.
Rather than the dipsticks detecting.
No, I know. It's just unfortunately that's the only time that you might get potentially a test. So it's just trying to look at ways in which they might pick up. But clearly, I mean, there's good evidence from looking at extensive GP data sets, laboratory data sets, that effectively anemia and a raised ESR is probably your earliest marker. And anemia starts to occur usually around a year to 2 years before actually a patient presents with myeloma. So it is quite an early marker of disease. Unfortunately, anemia in general practice is often thought to be iron deficiency. So patients often end up going down the wrong pathway because it's assumed to be related to iron deficiency, and therefore gastrointestinal investigations get performed.
Okay, thank you. Can we have the next question, Jo? I think we may need to make the final.
So Fenella, for you, paraproteins most resistant to treatment.
Okay, so generally in terms of being associated historically and also, you know, currently with poorer risk disease, sort of the light chain myelomas and the IgD myelomas, but actually it's not as simple as that. So we tend to, in all patients, we'll be doing thorough sort of risk analysis and trying to assess prognosis at diagnosis. And actually that's becoming more and more sophisticated, and paraprotein is a very blunt tool. We'll be using FISH analysis to look for high risk chromosomal abnormalities, and obviously going forward looking much more specifically at genomic level information to really pick out high risk disease. So I think, you know, historically a lot of the poor risk associated with light chain disease was associated with the renal component of that disease, but going forward it's much more sophisticated in terms of looking at genomic data and chromosomal abnormalities.
Thank you. Okay, final question from Sarah Glover. What would you recommend as a full profile for GPs to request if they suspect multiple myeloma, Fenella?
Well, obviously, we've just generated a GP tool to try and help GPs with that request. I think Ross explained very clearly last week the importance of having the combination of serum protein electrophoresis and either urinary protein electrophoresis or serum free light chains, so that you're looking at both intact and light chain disease. And then obviously the other thing that's important is the associated potential end organ damage. So looking for anemia, so a full blood count, bone profile and renal function. That is what I would say is a complete screen for myeloma.
Okay, thank you, Fenella. Okay, so if we could stop sharing the screen now, Joe, and I'd like to just thank all of our panelists of speakers today and in all previous weeks, and to everyone at UK NEQAS who've made this series of webinars happen, and for everyone for taking the time out to join us today. I'd also like to say an especially big thank you to Myeloma UK for their support throughout this webinar series. And I hope you've all found the sessions both beneficial and enjoyable. And we will be in touch shortly with the links to the webinars, as well as all the questions and answers from the last 4 or 5 weeks. So thank you all very much, and I hope you all stay safe. Thank you.